Thank you all for joining us for Navigating Spine and Pain Care, brought to you by Axis Spine Center. We're going to allow everybody a moment or two to get logged in, and then we will begin the program. Again, thank you all for joining us. We're going to allow just 1 or 2 minutes for everybody to log in, and then we will begin the program. Thank you all for joining us tonight for Navigating Spine and Pain Care. We are going to give everybody 1 more minute to get logged in, and then we will begin the program. Thank you for joining us for Navigating Spine and Pain Care. We are now going to begin the program with Dr. Jessica Jamieson.
Thank you for joining us tonight. I'm Dr. Jessica Jamieson with Axis Spine Center, and I think we'll start by just going down the line and kind of introducing ourselves. We're missing 2 who may come in here in the next few moments, but let's start over here. Ivanka.
My name is Ivanka Tran. I'm a physical therapist here at Axis Spine Center, and I'll be doing one of the presentations today.
And I am Dr. Roland Kent. I'm a spine surgeon here at Axis Spine Center, and as we have the opportunity with our portions of the presentation, we'll give a little bit more background information about us, but we're excited that you could join us this evening. Dr. Joe Kent, who is an interventional pain specialist, will be back in just a moment. In fact, I believe that this is him. I'll allow Dr. Joe Kent to introduce himself.
Hello, I'm Dr. Joe Kent, one of the pain doctors here at Axis Spine Center. Thanks for joining us this evening.
And then also not with us right now, as he's just finishing up in the operating room and is going to be sprinting over here to participate in our webinar, is Dr. Daniel Blizzard, who's also a spine surgeon here at Axis Spine Center.
Okay, so without further ado, we'll get started here. We do want to encourage questions, so we're going to leave some time at the end for a question and answer session. Make sure that if you have questions, you put them into the question box, which is on the navigation screen. Alternatively, you can raise your hand when we get to the question and answer session, and we'll try to unmute you so you can ask the questions. So this first slide is the learning objectives. This is supported by an educational grant from Nevro Corporation and jointly provided by Evolve Medical Education and Mantra Meetings. This was all emailed to all of the attendees, but this talks just a little bit more about our disclosures and the off-label statement and the disclaimer as well. Tonight, we're going to go through quite a few things in sort of rapid fire fashion. You'll get an email with a link to the recording of this so that if you have things you want to re-listen to, slides you want to look back at in the future, you'll be able to do that. We'll start by talking about acute radicular pain. How do we manage that? What are the options for that? What does the physical therapy actually look like for that? We'll talk about when to operate. We'll move into things that are new in both spine and pain care. We'll talk a little bit about research studies and some of the ongoing research studies we have here at Axis Spine Center and why we think they're pretty important. And then we'll move into the multidisciplinary approach that we offer here and kind of talk about why does that matter? What does that look like? And what does it do for our patients? And then we'll move into question and answer time after that. These are the learning objectives for tonight's CME. At the end of the presentation, there will be a link to claim your CME. You'll have 48 hours to do that after this live performance. That sounds very exciting. Here's the speaker disclosures again. And we will go ahead and move into the assessment and exam and the pain generators.
There are quite a few things that are annotated on these slides, and in full disclosure, it was Dr. Blizzard who was originally going to teach this portion, and if he arrives here, we will turn this over to him. But while there is a lot of information on the slides, I want everyone to concentrate a little bit more on some of the simplicity that hopefully we're going to present as we go through the concepts that the slides represent. And just a little bit more background about myself. I was in the Navy for 20 years. I trained actually at Uniformed Services University of Health Sciences, and then did an orthopedic residency in the Navy, followed by a civilian fellowship at Harborview Medical Center. and then was able to return to the academic center where I trained and was able to help train residents and fellows for several years after that time. And in that time, both working with medical students, orthopedic residents, and spine and PA fellows, et cetera, I found that there's a lot of excitement and perhaps angst associated with dealing with spinal issues. And a lot of that just comes from our education. And unfortunately, most of us who are trained either at an allopathic or osteopathic medical school or in other types of medical training don't have a lot of exposure to spine. And so I found, as I was teaching these principles to large numbers of people over several years, that keeping this simple was really the most important thing. And so I would ask that you don't get lost in a lot of the anatomy, that you don't get lost in a lot of the information that's presented on the slides, and we'll try to keep this as simple as possible. And so with the idea of an assessment and examination for spine, I like to keep it as simple as we possibly can. And I used to tell my residents and the people that were working with me that the most productive approach to a patient with a spine-related problem, whether that be back pain or radicular pain, or evidence of central stenosis in the case of neurogenic claudication or cervical myelopathy, is really to gather most of the information from the patient themselves. And so what's very important, obviously, is the appropriate types of questions to speak with patients. And I used to counsel my residents to go into the exam room before having looked at any x-rays, before having looked at any MRIs, which to most of us, especially without a specialty training in spine, are confusing. Even if we read through the radiology reports, that can be somewhat confusing. But instead to go in and just simply listen to the patient and get an idea of what their chief complaint is. And I used to tell every single resident that was rotating through my service that if you can walk out the door and come and present to me with a chief complaint, then that's usually the most useful thing. And then the history of present illness and what the patient explains to us in regards to that chief complaint can be very helpful. But for example, if a patient comes into my clinic and says, "Doc, I've got pain radiating down my right leg," all of a sudden my mind sort of compartmentalizes about the idea that there may be some type of nerve compression. And then I can think of all the different anatomical varieties that lead to nerve compression. That's really beyond the scope of what we're talking about right now. But the next thing that my mind goes to is, one, trying to find out which nerve that is, and two, trying to find out whether this is really an emergency or not. And we'll get into some of the things that sort of classify our problems as an emergency versus something non-emergent that we can take a little bit more time to watch and re-examine and exercise conservative care. And what we'll try to really drive home tonight is that conservative care really should be the mainstay of treatment. But the nice thing about a neurologic examination, which is the most important foundation for an appropriate workup of a spine patient, is that it's a little bit like a wiring diagram. And I tell all the folks that rotate through our services, whether that be here at Access Spine or when I was in the Navy in an academic center, to really think about that wiring diagram. And it's not important to really understand every single muscle that is innervated by the L5 nerve root, but it is somewhat important to know how to examine the muscles of the lower extremity or the upper extremity. And it's important to know where to look so that you can get an idea of what, say, extensor hallucis longus weakness or ankle dorsiflexion weakness means in the context of nerve compression. And the most common nerve compression that we see in the lower back is the L5 nerve. And the most common nerve compression that we see in the cervical spine is either the C6 or the C7 nerve. And so if you want the most bang for your buck, it's important to maybe memorize those things. I was just relating to the group here that when I was training, we used to carry a little book around called Maxwell's. And in that Maxwell's, there was both dermatomal distributions and there was a diagram that showed which muscles were innervated by which nerve. And so the majority of folks that I helped train had access to similar reference material that they would carry around. And so as they would come and present the chief complaint and a history of present illness to me, I would ask them, okay, what nerve do you think is involved? And the majority of the time they were correct in just using simple reference materials. So what tends to happen instead, unfortunately, is we get scared, our eyes glaze over a little bit, someone mentions a spine-related problem, we say, oh my gosh, I don't know that I'm equipped to deal with this. I would ask you to just take a step back, take a deep breath and say, okay, these things follow typical patterns and I want to do my best to figure out what pattern this might be. And so in this slide, we see some of the patterns that you're going to see associated with nerve compression. And this talks about some of the different things that if a spinal nerve, such as the L5 nerve root, is irritated, these are some of the things that can irritate it, either a mechanical irritation from actual compression versus chemical irritation, which is thought to be secondary to the disc herniation. And then in some cases, it's associated with instability in the case of spondylolisthesis. And this is a fairly common problem in which people will come in and complain of either upper extremity or lower extremity pain that radiates from their neck or from their back. And the good news is that this is something that's usually self-limiting. And so reassuring the patient a lot of times is the #1 key to helping that patient have success in the treatment of their particular problem. Any of you who have had radiculopathy before, whether it be upper extremity or lower extremity, know that this is very painful. And if these symptoms are ongoing and acute, a lot of our patients are looking for whatever sort of fix we can give them. And sometimes just giving them the right amount of information and helping them understand that this is usually self-limited is very helpful. So again, in the assessment and examination of someone with a disc herniation, this is usually very specific. And so from the physical examination and from the history itself, looking at the patient's dermatomal distribution of pain, sometimes the patients will have some insight as to which muscles are weak, but most of the time we can elicit that from our physical examination. My favorite physical examination maneuver, to tell you the truth, is just to watch people walk. And from watching people walk, and a lot of times I'll do that as they're coming into the clinic or being seated in the exam room, I can tell a lot as to whether it's an L3 nerve, an L4 nerve, an L5 nerve, or an S1 nerve, just based on the muscles that are weak associated with their gait, etc. And so once you can make that diagnosis, then I feel it's appropriate to then reference our workup material, or if appropriate, to order the MRI or the complex imaging. I would argue that no complex imaging should ever really be ordered in someone who hasn't had standing dynamic x-rays as well. And so that's part of the important assessment and examination. If you believe that someone deserves complex imaging, I would also recommend that they get standing, either lumbar or cervical spine films with flexion extension views, because that's really the only way that we can definitively diagnose instability. And it's important to diagnose instability because our treatment strategy for someone with, say, an unstable L4-5 segment with lumbar disc or lumbar radiculopathy may be very different than someone who has an acute disc herniation, both from a conservative and a surgical treatment standpoint. And this kind of gets into the anatomy, the actual location of the disc. And I prefer this slide just because obviously it's a little less busy than the last slide. If you look at the image on the right-hand side of the slide, the most common spot for a nerve to be involved is where you see the blue circle. We call that the lateral recess within the spinal canal. And at every single level of the spine, so in this case, we're looking at an L4-5 segment, and you see the L4 pedicles represented by the image that's on the left. And you see a nerve that comes down underneath that L4 pedicle. That nerve is termed the exiting nerve root. And in this case, it's the L4 nerve root, as we're at the L4-5 segment. That is a less common site of compression, but when you're reading a radiologic report and they talk about neuroforaminal compression at the L4-5 segment, they will often say, please clinically correlate with an L4 radiculopathy. That's the red circle that we see. Again, less common. More common is the blue circle that we see, or the lateral recess. And at the L4-5 segment, the nerve root that is affected by a lateral recess disc herniation is the L5 nerve root, also known as the transiting nerve root. And so if you were to take the same information and transpose it to, say, L3-4, the most common nerve root to be compressed at L3-4 would be the L4 nerve root in the lateral recess. This is really beyond the scope of what we need to learn to be able to just simply approach spine surgeons. But in the idea of trying to find correlating anatomy that might be responsible for, say, an L3 nerve root problem, it's important to look at both L2-3, where it's the transiting nerve root, and at L3-4, where the L3 nerve root is the exiting nerve root. And again, this is just sort of another way of saying the same thing. The cervical spine's a little bit different. I just mentioned that there's two nerves that can be affected at every level of the lumbar spine. The nice thing is that those nerves correlate with the level we're talking about. So if it's the L4-5 level, it's L4 and L5. In the cervical spine, there's really only one nerve that can be affected, and that's the exiting nerve. And that's just because of the differential anatomy of our cervical nerve roots and how they exit the spine. So say it's C6-7, which is also represented on this image. The only nerve that can really be affected is the C7 nerve root. In the case of obviously central stenosis, then the spinal cord can be affected as well. Thankfully, that is also less common than say cervical radiculopathy. And so as we start looking at other potential causes, so someone comes in and says what our primary complaint is, a lot of times is axial back pain. And so from a surgical perspective, I try to make this as easy as possible. That axial back pain is typically associated with either discogenic, meaning pain coming from the disc, or facetopathic, or pain coming from the facet itself, versus instability. Those are the two main causes, or I guess 3 main causes of axial back pain. It should be noted, though, that stenosis, whether that be stenosis impinging on a single nerve root or central stenosis causing neurogenic claudication, can also cause axial back pain. And a lot of times treating that stenosis will go a long way to treating a patient's axial back pain as well. Radicular pain is what we've just been talking about. Things to be very concerned about, and this is what most of us get the most nervous about. If you work in an emergency department or an urgent care environment, then you'll think a lot about Caudal Equina syndrome. And Caudal Equina syndrome, the primary presenting symptom is actually back pain. And so that gets confusing because a lot of people coming in with back complaints will also have back pain. Back pain in and of itself is obviously not the worrisome symptom in Caudal Equina syndrome. Instead, again, relying on patient history to make this diagnosis, you're going to see severe radicular type pain. This can be unilateral or bilateral. And then, of course, the things that we worry the most about are urinary retention, bowel incontinence, saddle anesthesia, and typically associated with lower extremity weakness. And this is thought to be a surgical emergency. And obviously, to retain as much function as possible, we'd like to be able to get patients with Caudal Equina syndrome very quickly to the operating room. But to that end, in patients who come in with back related symptoms, that sort of becomes my review of systems. And so often I ask that patient as I get to this sort of interview portion of the examination, do you have any bowel or bladder incontinence? Do you have any saddle anesthesia? And the majority of time, patients will say, no, I don't. Occasionally, in the case of acute Caudal Equina syndrome, they're so distressed that they'll bring this up usually first off. But in the cases of chronic Caudal Equina syndrome, which happens with slow degenerative stenosis of the lumbar spine, they may even tell you that it's been going on for 10 years. And that, if it's been stable for 10 years, is obviously not acute Caudal Equina syndrome and probably less urgent. And so the periodicity or the length that they've had those symptoms is also important. So this talks a little bit about instability of the spine. We'll get much more into this, but instability of the spine is usually functional pain, meaning that as a patient arises from a seated position or they begin becoming active, the pain gets worse. And as they become more sedentary, lying down at night, for example, or sitting for long periods of time, a lot of these people will report doing well in a recliner rather than laying flat in bed even, but the pain will typically abate during sedentary periods. And so that can be helpful in helping to diagnose instability of the spine. Again, we talked a little bit about mechanical back pain associated with this. Neurogenic claudication, I think, is one of the most missed diagnoses. And my wife gets very tired of me as we walk around Costco looking at people saying, ooh, I could help that guy, or ooh, I could help that person. And the majority of the time when I'm doing that, I'm looking at someone who's sort of shuffling, leaning forward, has difficulty taking purposeful steps. And those patients, typically older males, but also with older females, they have neurogenic claudication. And I can tell actually when they walk into the clinic most of the time that I'm going to find lumbar stenosis. And it's usually multi-level lumbar stenosis, the most common levels being L2-3, L3-4, and L4-5. What's also very important to realize with neurogenic claudication is that tightness around the neural elements can cause back pain, as well as leg pain, and those neurologic symptoms, meaning the unstable gait. And the back pain can improve dramatically with treatment of the Caudal Equina syndrome. It used to be thought that if someone had back pain, neurogenic claudication. It used to be thought that if someone had neurogenic claudication and back pain, that a fusion surgery was appropriate. But I actually disagree with that for the most part. Fusion surgery is appropriate in the case of instability. If someone simply has lumbar stenosis, most of the time their axial back pain, if it accompanies the neurogenic claudication, will improve with treatment of the lumbar stenosis. This is thought primarily to be a surgical problem and does not normally improve with time. And so again, this is sort of the pathoanatomy or the anatomy associated with instability. And here we see an L4-5 segment that's become unstable. And typically in the case of degenerative instability, what's happening here is that the facets, the primary stabilizing joints at the back of the spine, become old and arthritic, and they no longer can fight against translational motion of that L4 segment on top of the L5 segment. And unfortunately, the nerve at risk here is the L5 nerve root in the lateral recess, or that transiting nerve root. In the case of, say, a spondylolysis, in which people have a pars defect, for one, it's actually usually at the L5S1 segment, but the nerve root at risk is typically the exiting nerve root, the one in the neural foramen. And so if it's L5S1, conveniently, that's also the L5 nerve root that will be affected. These are some of the dermatomal patterns. And again, it's beyond the scope of our discussion tonight to memorize all of these, but know where to find them, because this can be very helpful in, again, sort of reading that map and helping understand as a patient comes in and complains about pain radiating down their leg, whether this is the L5 nerve root that's being compressed or the L2 nerve root, etc. And these, again, dermatomal distributions, don't memorize it, know where to find it. And these are the primary muscles. Again, something that if you have good reference to, and the more you become exposed to these, after a while of looking this up, you'll get to the point where it's very quick and easy to say, hey, that's an L5 nerve root mediated muscle, and be able to make that diagnosis quickly. And so again, I mentioned sort of the importance of gait. Once we get to the physical examination, I actually find this to be the most useful. Someone with an L3 radiculopathy, for example, has demonstrable quadriceps weakness while they're walking, and they'll walk with what's known as a quadriceps avoidance gait, and they'll actually lock out their knee as they're walking. In someone with tibialis anterior weakness, which is an L4 nerve root mediated phenomenon, they'll walk with a steppage gait because they've got a foot drop and they're concerned about tripping over that toe. So they'll walk with sort of a high knee on that side. A Trendelenburg gait with hip abduction weakness is suggestive of L5 radicular symptoms because the gluteus medius is innervated by that nerve. Again, as you begin recognizing these patterns, it becomes very easy to know which nerve is involved. And then in the case of, say, a Trendelenburg gait, I'm going to look at the MRI for either L4 or 5 issues within the lateral recess or L5S1 within the neural foramen. Stretch signs are simply just that, a straight leg raise when the patient is either seated or lying down. That puts enough stretch that it re-irritates the nerve. And then reflexes, keep in mind that our lower extremity reflexes are really just L4 and S1. So L4 patellar reflex, S1 Achilles reflex. Don't memorize it, look it up. Again, I already mentioned upright x-rays can give me a lot of times more information than even an MRI. If you're thinking about an MRI, get an upright x-ray as well with flexion extension views, and that'll be very helpful in making the diagnosis.
All right, I'm going to take over. I am Dr. Joe Kent, and I am the newest member of the Axis Spine team. I am an anesthesiologist by training, and I did an interventional pain fellowship at Oregon Health and Science University, and I've been here for year and a half, going on 2 years. And so what I'm going to talk about to start with is treatment options. And we're going to go over 4 main categories. Physical therapy, I'm going to leave to Ivanka because that's her expertise. But I'm going to dive into a little bit more on the medications and some studies on injections, and then surgeries, obviously what Dr. Roland Kent and Dr. Dan Blizzard are going to talk primarily about. So first off, physical therapy, just real short. Dr. Roland Kent mentioned, 90% of patients will improve, with these radicular symptoms up to 3 months out, 80 to 90%. And so usually physical therapy, conservative care alone, and the vast majority of these problems will improve. But it's important to maintain function and reduce disability, and that's where physical therapy primarily comes in. So main categories, medications that we're going to talk about, acetaminophen, NSAIDs, oral corticosteroids, gabapentinoids, and opioids. And so those we're going to kind of slog through all of those. So first off, we have acetaminophen. There isn't a whole lot of studies out there looking at acetaminophen for acute, radicular pain, because it's not thought to be a very potent analgesic. But there was one done here. I believe this was an Israeli study. It was an ED setting, 21 to 65-year-olds with acute radicular symptoms. And what they did is they looked at morphine, a gram of IV acetaminophen versus placebo to see basically how much that improved their pain. They ended up with 300 patients and 100 in each group. And this is kind of the big takeaway here, and we're going to focus on acetaminophen. The baseline VAS was around 78, so around an 8 out of 10. 15 minutes after IV infusion, we're looking coming down to about a 6 out of 10, and 30 minutes about a 4 out of 10. Pretty good, looking at acetaminophen. But if you swing over and look at placebo, well, they also went from an 8 to a 7 to a 6.5, and so it does help, but it's probably not a powerful analgesic, especially for these acute radicular symptoms. Next, we're going to dive into NSAIDs, and this is a Cochrane review looking at NSAIDs for sciatica. A lot of studies out there. They specifically honed in on about 10 trials, only one of which was they felt to have low levels of bias. But 5 trials used adequate doses of medications. 2 trials did not use kind of the OTC recommended dose. 3 of the trials used NSAIDs that are no longer used in humans. But we're going to start with those 5, and those appropriate doses were evaluating diclofenac, meloxicam, piroxicam, lornoxicam, and ketoprofen. And specifically, some of the newer NSAID medicines like the coxib, celecoxib, rofecoxib, were not included. And this treatment duration was anywhere from 4 to 14 days. So looking at pain reduction, NSAIDs versus placebo, well, they essentially found there was not much of a difference. There was no difference between the two. 3 trials compared NSAIDs to placebo for function, and maybe a slight improvement in function, but again, not much of an improvement, overall. 4 trials were looking at adverse effects, and surprise, surprise, the NSAIDs had a higher level of adverse effects. And only 1 study looked at disability, and they found that NSAIDs were no different than placebo. And so essentially, NSAIDs for acute radicular pain, sciatica, is no different than placebo, and is associated with risks, including GI problems, nausea, upset stomach, that type of thing. Moving on to oral corticosteroids, and we see a lot of patients who come in who've been prescribed oral corticosteroids prior to them seeing us. And so this is a particular study. This was in JAMA 2015, so relevant study. It was a randomized double-blind placebo-controlled trial. 269 patients with radicular pain less than 3 months and a disability scale greater than 30, and with a positive herniated disc on MRI. And they were randomly assigned into 2-to-1 tapering doses of oral prednisone. And their primary outcome was functional change at 3 weeks, but they also looked at the functional change at 1 year, the changes in pain, spine surgery. Did these patients avoid surgery? And they also looked at some of these other markers for disability. And what they found was that in the patients treated with prednisone, they did have a slightly improved ODI score at 3 weeks. That was significant, and they also showed at 52 weeks there was an increase in their ODI score. It was a small increase at 6 to 7 points, but it was real. Looking at pain, they actually didn't show any change. So there was no difference between patients treated with an oral corticosteroid versus those who received placebo at both the 3 weeks and the 52-week mark. From a prednisone group, looking back at some of these other functional scores, there was no difference in some of these other functional scores, such as the SF-36, the physical and the mental aspect. There was no difference in surgery at 52 weeks at follow-up, and so they were not able to avoid surgery by taking oral corticosteroids. And they did have, people who took prednisone had more side effects. Next, we're going to get through some, the newest thing, for acute radicular pain, gabapentinoids, and this has been a hot topic because of, trying to avoid more opioids for these symptoms. And so this is a New England Journal of Medicine. There's a randomized double-blinded placebo-controlled trial looking at pregabalin. I put too many words in here, so we're going to get through here pretty quickly. But this was basically patients who presented with moderate to severe sciatica and had dermatomal pain, myotomal weakness, sensory deficits, or diminished reflex, determined by the trial clinician. And they were looking at, and they had to have pain that was minimum for a week and maximum of 1 year. So it was a pretty wide range. Some of the exclusion criteria, if they've had any other procedures done for pain, had contraindications, pregabalin, that such thing. The starting dose was 150 milligrams, so 75 milligrams twice a day, or a matching placebo. And this was titrated up to a maximum of 300 milligrams twice daily, depending on how they tolerated it. And we'll kind of skip ahead from here. And so basically how they did is if they had an inadequate response to pain, they kept escalating dose until they reached that target. The patients were allowed to receive additional care if it was the trial clinician felt like it would be reasonable. This included, things like physical therapy, other medications, that type of thing. The primary outcome was the average leg pain intensity over the course of the previous 24 hours. And it was also assessed at 8 weeks and at 52 weeks. And they had some of these many other secondary outcomes looking at disability. Table 1, just looking at basically these two groups. There were 106 in the pregabalin group, 101 in the placebo group. The pain, where was it? Intensity score kind of 2/3 of the way down, about 6 on both sides. Looking at the primary outcome and secondary outcomes, essentially the take home is there was no difference between gabapentinoids and placebo. And this was at 8 weeks and 52 weeks. We have Dr. Dan Blizzard here, who's done saving someone's life in surgery.
Just want to be fashionably.
And so we'll move on to him here in a minute. What else? So in conclusion, gabapentinoids, no difference between pregabalin and placebo. And so for acute radicular pain or sciatica, gabapentinoids, pregabalin, gabapentin really did not show much of a difference between placebo. This is a little different from the research on chronic use, and we're not really focusing on chronic use, but there is a role, and I just kind of put a little table down there on the bottom there. There's a role for gabapentinoids in patients with chronic radicular pain. Moving on now to opioids. Well, there isn't really a whole lot of studies looking at opioids for acute radicular pain. The one Israeli study that we talked about at the beginning was one of the few that was actually out there. This practice guidelines is from emergency medicine, or environmental medicine, excuse me, basically stated that they did not recommend opioids or endorse opioids for radicular pain because they felt like that there was only marginal benefit and the risks are real. And so, but they said if you do prescribe opioids, make sure you have functional goals in mind. What are some things that you hope to obtain by taking these medicines? And if the patients aren't able to take them with escalating doses of opioids, then maybe you need to find another option. Now we're gonna get past the medications and move over to interventions. And for acute radicular pain, we're gonna primarily focus on epidural steroid injections. This is another Cochrane database looking at 25 clinical trials, a lot of patients, looking at patients who received epidural steroid injections, anywhere from greater than 2 weeks or less than 3 months as far as the follow-up. And what they found was that epidural steroid injections were slightly more effective compared to placebo in reducing disability at short term. They were also slightly more effective than placebo in improving pain relief. But the numbers were small, a negative, 5 on a 0 to 100 scale, pretty small. And so their conclusion, and this is a Cochrane review, was that epidural steroid injections might produce a little bit of relief and improve in disability in patients with this lumbosacral radicular pain. And more importantly, there were no minor or major events. So that is important to keep in mind that it is a very safe procedure. I wanted to throw this in there too, because there's also been some debate in the pain literature looking at, well, what are these studies, what are they comparing to? Is it an active placebo or is it a true placebo? And so Stephen Cohen, who's the author on this article in Pain Medicine, this is from 2013, basically looked at patients or studies who basically looked at epidural injections versus non-steroid epidural injections versus non-epidural injections, and was there any difference? Is there something to physically putting something in the epidural space? And what they were able to glean from looking at these 43 studies, that basically the epidural non-steroids were more likely than non-epidural injections to achieve positive outcomes. And it also provided greater pain score reduction. Specifically looking at the studies that looked at epidural non-steroids compared to epidural steroids, there didn't seem to be a whole lot of benefit from adding the steroid. This was at 22.9% in favor of the steroid. But when they looked at the studies that looked at an epidural steroid injection compared to a non-epidural injection, so not even anywhere close to that epidural steroid or that epidural space, there was actually much more of those studies, almost 60% of those studies favored an epidural injection. And so their inclusion, there seems to be something to putting something into the epidural space in these patients who have acute symptoms. And some of the studies may not be able to tease that out just because maybe they're not using a true placebo. Now we're going to move on to Ivanka to talk about physical therapy.
Dr. Kent, I've got a quick question for you. Say you're in an acute care scenario or you're a primary care provider and someone comes in with 1 week of acute radicular pain, no neurologic deficit, but they're clearly uncomfortable. What are you going to do for them? Is there a cocktail? Is there going to be a go-to medication out of those things that you just mentioned?
That's a great question. That is, if we had great studies looking at, these different medicines, I think, everyone would be using one. And the thing is right now is why you see people using different medicines is that there isn't a goal, a silver bullet for each patient. I think the idea is you need to talk with your patients and come up with goals and get them as, reduce their disability as much as possible. And so if they are bedridden, then, trying to use various medicines. And if that means opioids, using opioids to help them, take a shower, brush their teeth. And so I think, there are a lot of different medicines. There isn't a silver bullet, but it really comes down to the patient and, trying to set up goals and give them medicines that can achieve those goals.
Perfect. And I think that's one of the benefits of just having this comprehensive system too. Just everyone's got a little piece to this whole picture. So from my standpoint, often I'm getting referred these patients from pain management often, since their first intervention is often seeing if you can manage the pain a little bit better so that they can participate in physical therapy. So when I see them, I define radicular pain as just, as we've discussed, is just compromise or compression of the spinal nerve root. So at that point, I'm not really concerned particularly. I'm not going to be doing the surgery on them, but just saying that they've got these radicular symptoms going into either their upper or lower extremities. Today, we kind of focused on the lumbar ones. So, and everyone has stated, anywhere from 80 to 95, 92% that really conservative management is the way to manage this if at all possible. And I guess what I usually discuss with patients is just, if you're taking something out of that space, that material that you're taking out is a spacer that's meant to last your lifetime to give you some shock absorption. So when you're taking that material out, you're adding compression to those facet joints down the line and hastening further degenerative changes. So if you can manage it conservatively, you're going to centralize these symptoms, you're going to preserve some of that disc height and give yourself a little bit more longevity in terms of facet wear and tear. So conservative care, we're looking at whether it affects both legs more centrally, whether it's affecting single leg. The typical pattern is that it's going to affect one side more than the other, just with the mechanics of some of the disc extrusions and where that goes. With the ligamentum flavum in the center, it's usually going to go more one side or the other in terms of the extrusions. So if it's affecting both legs, often that's to me a sign that, ooh, this could be a pretty large disc extrusion more central. If it's a single leg, it's going to be just as Dr. Kent described, off to the side a little bit, right in that lateral recess area. So our target is kind of to see if we can work on, once we identify the nerve root involved, if we can centralize those symptoms to some degree. So I look on it, I always say to people, I give them the analogy of kind of tires on your car. So I say, we've got to centralize these symptoms, get the way the mechanics are working a little bit more even in terms of facet loading before we start any kind of exercises that are more geared towards strength. So the goal is to centralize the symptoms by, typically in our world, there's, research on McKenzie exercises, which is basically saying, can we pinch down on that section of the disc that's sticking out there to kind of centralize that a little bit more, because otherwise there's no specific way I can get right in there and do that. So there's a definite series of exercises that we work on, extension bias program towards pinching that extruded piece to move it back towards the center. So that also says to me, you know, it's a real advantage if we can get some of this pain management in with that, because obviously people aren't going to tolerate this repeated pinching that we're doing if it's really painful. And I also say, if people just go in and get the injections and then I don't see them for 3 months, it's kind of a waste a little bit of an injection, because the goal is to buy yourself time also with these injections so that you can participate, so that when the injection wears off, you're in a different place. You know, you have centralized your symptoms and you're able to get on to the next exercise program to actually prevent recurrence. So usually what I'll start with too is I'm usually measuring their functional active range of motion, because what I see is if we're having something sitting off more to one side than the other, they're going to have limited side bending to that side, and they're going to typically have limited lumbar extension too. So as mentioned before too, we're also screening for neurological involvement, bowel and bladder, central anesthesia, and doing the straight leg raise to see if we've got any compromise there. Oftentimes, I don't know why I put L1 to S1, but L5, S1, often the lower lumbar spine is the area where this is usually most common. And then what we're also doing, my basis in training is manual therapy. So what I try to do is, if I say, when I'm palpating on those facet joints for relative depth, if they're in an extended position, if one's sitting back a little farther, I'm saying, looks like the symptoms are on that side, they can't extend properly on that facet. So I'm going to do some unilateral PAs or central PAs. Always people are going to tolerate the central stuff better than the unilateral stuff. So I'll just start with central, see if they tolerate it. Unilateral PAs, if I can improve extension. Again, we're working on centralizing the disc a little bit. So this really is benefited by getting some form of anti-inflammatory medication or pain management to look at that. So we try to tailor that to work hand in hand together. And then what we're looking at is just restoration of getting back that bilateral extension. And I'll usually say to people, these side bending motions, just to give them a rough gauge, should be symmetrical within, you know, a 1/2 inch to 1 inch side to side. So they can just reach either side and see where they're at with that, and that they're not reproducing the symptoms when they do that. So we'll go through, the first step is going through these McKenzie extension exercises, central or unilateral. And then the other part that we often add is we'll do some version of traction or modalities. So we're just saying, if we can, kind of like when you pull a string with beads, centralize that a little bit, take some of the pressure off those facet joints, particularly if we've been mobilizing those to centralize the disc. That's going to help with pain management and modalities. So typically E-stim and traction. So here's just a little diagram. This is a typical thing. What we've done is put some little towels underneath their pelvis so that they're not already sitting in extension when we do this, because some people, it's so painful that we're starting in a little bit of a flex position, working on those central PAs at the level where we're finding the problem. And then we'll go on to unilateral PAs. You can do it more broad-based or go down to a smaller area if the patient will tolerate that. So the goal again is to just get back segmental extension with everybody. So this just is a diagram showing kind of the progression of that, starting low and seeing what they can do with extension. So that bottom picture where the person's really extended, the most important piece is just that they're keeping their ASIS level down. So I'll often say in our older population that we typically see, they're not going to be able to do what this diagram shows. We'll just have their hands out a little bit further. If that's too hard to do it in this position, we can also do a wall version of that. So the picture below shows unilateral side bending. So we're saying, okay, first we might have done wall press aways to get the central press away instead of lying down. Then we'll typically say on this diagram, it will be showing that on this left side, we're trying to get a little bit more extension there. So it's a repeated motion, again, to see if we can centralize those symptoms. After that, once we say, okay, the symptoms have really centralized, come out of your leg into your back, and those measurements look like they're pretty symmetrical, And the most symmetrical activity that patients can do that's extension is walking. So a lot of walking on level terrain. Typically we'll see patients, they go home and they say, oh yeah, I walked 10 minutes on the treadmill and I put the incline up. Well, that's a ton of extension. So I'll say, try to keep it flat, see if you can get that motion going a little bit first. And then we move on to core stabilization exercises once the radicular symptoms are centralized. So I just say to people, and I see people like this every day in the clinic that have moved on to these already, but they're still having the pain going down into their legs. So it's kind of a waste of time to do a ton of these core strength things when you still got those symptoms going into your legs. So the goal is pain management, centralization of symptoms, and then gradually progress through the McKenzie ones onto these core stabilization exercises. Otherwise, you're just gonna, you know, if you put new tires on your car and the car's still out of alignment, you're just gonna have off wear and increased pain again. So just a couple of diagrams. Lumbar traction is on the bottom. We use some of that here to try to centralize, and typically that's set at 50 to 75% of their body weight to decompress some of those facets. Research has kind of been up and down on this. At one time it was in big favor. It's kind of gone through a period of not so much in favor, but then it's returned again with a lot of traction / decompression, just to say, you know, 3 out of 4 back surgeries are to do with too much facet loading. So they feel traction is beneficial just in terms of equalizing that. And then the picture up above, electrical stim, just to see if we can calm down the spasm response if they've got irritation going on. Again, I think, I'm not sure if this is my side or the next, but again, obviously, if we're not making any headway with this and the radicular symptoms persist and or they have motor weakness or any of these bowel bladder, senile anesthesia, anything like that, then we're going to say, okay, time to move on and refer back to surgical intervention.
Ivanka, just quickly, what do you think about inversion tables?
Yeah, it's interesting because I've had a lot of patients come in with questions about that. So typically what I see is usually people are not I think it's okay to use. I just think a lot of people aren't using them right. Typically they're supposed to work, that you're just tilting, you know, 20 to 30 degrees, and that you're maintaining that for 8 to 10 minutes. If you're inverting all the way upside down and after 2 minutes your blood pressure can't take it and you're moving back up, there's a good chance you're going to repinch something on the way back up. And the other big caveat with this too is there's anything from the big 5, you know, inversion table that goes up to 175 pounds, and then there's a little more substantial one. So I had a gentleman come in 6'7", and I actually was at his house and he said, let me show you how I do this. And he just bought it and he tipped it down and it had a plastic buckle and the guy was too big for the thing and he just broke the back off the thing and the buckle flew off. So I said, you know, it really is something that you've got to be, you know, tailored to you in terms of the structure of the thing, and that you're getting a little bit more instruction on how to use it, not just follow the booklet that comes with it. So.
All right, so Ivanka kind of read through these real quick. Wind image, so no improvement in persistent symptoms, weakness. If they have an asymmetric neurologic exam that's new, red flag symptoms, those will want to get, you know, urgently. Then, you know, any sort of severe pain that's disrupting their daily living, they can't feed themselves, they can't bathe, they can't go to the bathroom, and that really needs some imaging. Red flag signs, so severe, rapidly progressing weakness, independent of pain, any sort of gait instability. They're walking around, they're kind of bumping into walls, they're, you know, walking around, they look like they're drunk. New bowel or bladder incontinence, new progressive difficulty with fine motor tasks, loss of grip strength. Any of those things that are new or progressing, that can be a reason to get imaging and get them in with one of our spine surgeons very quickly. If you do find that, what imaging do we want to get? Typically, if you are, you know, Dr. Roland Kent, you know, made a good point that getting, you know, x-rays standing with flexion extension to look for instability. After that, you know, if the patient has no history of any surgeries or anything like that on their spine, then an MRI without contrast should be sufficient. If there was prior surgery, or if there's concern for, you know, the patient has a history of cancer or infectious disease, then an MRI with contrast would be helpful. If there is a device that is non-MRI compatible, then really the only way we can really see the nerves to any substantial degree is get a CT myelogram. and that's when they put contrast in the intrathecal space. But if they only have low back pain only, it can be reasonable to get just the standing X-rays with AP lateral flexion extension. Oblique views don't really provide a whole lot of, at least in my experience, a whole lot of benefit. I would rather see these flexion extension views. And the MRI is going to show us those frame and lateral recesses a lot better anyways. So what do we do while managing surgery? So once a patient has been identified as a surgical candidate, really we're focusing on limiting disability and maintaining activities of daily living. These patients, the longer they go, the more likely they're to have the central hypersensitization, kind of develop these kind of long-term, month, year, lifelong, chronic pain. So the idea is to keep them functional, keep them as strong as possible, because they want to have the best substrate going into surgery. So keeping the muscles tight as much as possible, using medications and escalating as much as you need to maintain their activities of daily living. And these epidural steroid injections can be helpful for pain and functional improvement as well. All right. I think this is Dr. Blizzard in the house.
Finding the game. All right, so this has been mentioned, I assume, multiple times already because I've seen the slides. Most patients do symptomatically improve with conservative management alone. So the vast majority of people with back pain never come and see us anyways, and many of these patients never even seek care. If somebody has a lumbar strain, it goes away on their own. They never seek care, but even amongst those that do, they do resolve with conservative management and never ended up meeting me or Dr. Kent. In general, radiographic appearance does not strongly correlate with clinical symptoms. Almost everybody who comes to me, I ask them first why they're here or what bothers them, and they'll say, it's my L2-3 or it's my multi-level disc degeneration. I say, but what is your actual symptom? Because everyone over the age of 40, and studies show that numbers are actually 50% or more of anyone asymptomatic over age 40 are going to have an MRI finding. So just because someone has an important MRI finding or a large abnormality does not mean they have a symptom, and does not mean we need to operate on that MRI. So things that, kind of reiterating what Dr. Joe Kent already said, things that concern me as a surgeon when I start considering when to operate. So pain. I think people that require long-standing ongoing narcotics, I think that is an absolute indication for surgery. I think that's not a reasonable way to treat pain at this juncture, especially if there is a reversible cause of it, and something we can fix surgically. People that have significant ongoing limitations in their ability to work, significant limitations in their quality of life, and this is not for a week or two, but this is for months ongoing. People with lower extremity pain that follows a clear dermatomal distribution, so a pathway down their leg that makes sense for our understanding of anatomy. In low back pain that's often unilateral, and especially patients that have any instability pattern to their pain. That means people, Dr. Kent was talking about getting upright x-rays, people that have clear instability or motion of their spine in an abnormal way. When they stand up, their symptoms should be worse. When they bend forward, it should clearly be worse. When they lay down, it should get better. People that have back pain that follows that pattern, as a surgeon, I'm thinking they have a problem of instability, and I'm interested to see what that x-ray shows. Other indications to operate. People with acute weakness, acute weakness can resolve. So if someone comes in with an acute foot drop, that doesn't mean we need to rush them off to the operating room immediately. Acute foot drops can improve. However, someone with progressive worsening of a foot drop, someone who says, my foot feels a little clumsy, 6 weeks later, gosh, it's really clumsy, 6 weeks more, I have to wear cowboy boots to get around. That's someone where I say that's going the wrong direction, we need to intervene. But just because you have an acute foot drop or weakness doesn't mean you need to rush to the operating room. And numbness is the least predictable thing to improve with surgery. So in my mind, numbness is not a hard indication for surgery. If it's painful or burning numbness, because people can describe their numbness in different ways, that burning type of numbness is much more of an operative indication. So this gets back to a lot of the ideas for treatment. So this is a picture of, you don't have to outrun the bear, you have to outrun your friend. So it doesn't mean you don't have to be fast enough, or you don't have to be complete enough to make disc herniations entirely go away. What you need to do is create just enough room to make that nerve unhappy. So a lot of these things we do that are conservative, and patients say, I have this huge disc herniation, I need this huge surgery to get it all out. I tell people what you really need is just enough, even like a millimeter more space for your nerve to make your nerve less unhappy. Steroid injections, what do? Pinch nerves, when they get pinched, they swell. Suddenly if a nerve's already pinched, it's swollen, now it's even more pinched. So how do steroids actually work in my mind to treat symptoms? They shrink the nerve back down to the size it began as, and maybe that nerve can be happy with that. Now, when the nerve's constantly getting pinched, and it's going through that circle of getting pinched, swelling up more, getting pinched, swelling up even more, it's never going to be happy. Same idea with physical therapy and centralization. If you can offload a little of the pressure on the nerve, that might be enough to push it past the threshold where it bothers somebody. So even if the disc herniation is massive, it doesn't mean it has to have a surgery. The overall goals of surgery. So there's two primary things we do as surgeons. We decompress, compress nerves, and we stabilize unstable spines. All spine surgery can be broken down to those two things. That's all we do well, and it's all we reliably should be doing. So when it comes to decompressing spines, we take away disc that compresses nerves, bone spurs, fat that gets trapped inside the canal, and oftentimes the overgrown ligamentum, that ligamentum that lives inside the canal that your body can make more of to try to make you stable when your body becomes unstable. And we can stabilize spondylolisthesis. So that's an unstable spine or a slip disc. That's when we look at the dynamic motion when people stand up and they flex and extend. We look at those x-rays. If I see a spine moving backwards and forwards and they have pain, that's something that's going to reliably get better when we can stabilize it. So fusion, decompression, or both. These yours?
Yeah.
I can talk about it.
So obviously both Dr. Blizzard and I spend a lot of time thinking about these things and working with patients who have these things. And I really appreciate what he said in segue to what I'm going to talk about. Is essentially we do two things as spine surgeons. We make more room for neural elements that are being compromised by stenosis or tightness, or we stabilize unstable spines. And so I just wanted to quickly go through how these different scenarios manifest themselves clinically. So cervical stenosis comes either peripherally, which is pressure on the nerve root causing cervical radiculopathy. We mentioned that just at the outset, that this is typically very specific. And as people are somewhat of a wiring diagram, dependent on where they have weakness, we can make this diagnosis back to the resident that's trying to find the chief complaint of the patient. If it's a C5 radiculopathy, they'll have deltoid and biceps weakness with pain radiating down to their thumb and index finger, obviously, or staying within their deltoid region. And then we get to the less specific, which is cervical myelopathy, or actual pressure on the cervical spinal cord. And you can see this on the image on the left-hand side of the screen, in which because of the degeneration, the spinal cord itself is being impinged upon centrally. And what happens with most of these patients is that they begin losing fine motor coordination. And so I'll ask these patients, are you able to button up your blouse? Are you able to pick up a coin off a flat surface? What do you like to do with your hands? Is it difficult to do these things? Do you have more difficulty signing your name, etc.? And a lot of times they can give you a historical, they can give you history to their medical condition that helps you establish that diagnosis. Thoracic stenosis, thankfully, is relatively uncommon, and it's relatively uncommon because there's very little motion of the thoracic spine. In general, it's stabilized by the rib cage, and with less motion, it's less subject to deterioration, but it can happen. Thoracic radiculopathy, again, a more lateral compression of neural elements or a specific spinal nerve root, and that typically follows a dermatomal pattern. And so you'll have people that say, I've got pain that starts in my mid-back and radiates around to the front. And based on that dermatomal pattern, often you can try to figure out which nerve is involved. But obviously, the mainstay of diagnosis in this case would be an MRI, in which we're able to see which thoracic level is involved. And then thoracic myelopathy. This is a case in which the spinal cord is being compressed below the brachial plexus or below the nerves that innervate the upper extremities. And so they'll have spasticity of the lower extremities with no upper extremity involvement. And so it's important in these cases, if you're doing imaging, probably to include both the lumbar spine and the thoracic spine to make this diagnosis. And then lumbar stenosis. Again, peripheral stenosis causes lumbar radiculopathy, and central stenosis causes neurogenic claudication. And simply put, that's just difficulty walking long distances because of central stenosis of the lumbar spine. And it typically resolves with leaning forward or with sitting. And so you'll have patients that will give a history of being able to walk 1 or 2 blocks when previously they could go out and walk for 5 miles without a problem. Yet if they sit, it hits the reset button and they can walk for another 1 or 2 blocks. And so the answer for any degree of tightness is simply put, making more space. And this comes in several different flavors. And this gets, again, beyond what we really need to get into today. But the interesting thing about simple decompression of the lumbar spine, meaning decompression of neural elements without fusion is that it hits many of the buzzwords that people are even using today to advertise themselves as cutting-edge spine surgeons, in the sense that it's minimally invasive by nature, it's motion preserving, and it allows for surgical intervention that people can recover from quite quickly. And lumbar laminectomy, for example, was described first 130 years ago and was performed by a British surgeon 130 years ago. And essentially, the technique that we use today is not entirely different, though there are some different modes, and we'll mention some of these, that we hope that we can do this through a slightly less invasive means. But to be honest, it's a very round wheel, and anything we try to do in that time, we're just trying to make it rounder. And so generally, folks with compressive pathology that fail to respond to time and other conservative treatment, especially in the case of worsening neurologic condition, we feel that these are generally surgical problems and generally have very good surgical solutions, with lumbar laminectomy, for example, yielding 98+% success rates associated with the appropriate patient population. And so then we move into instability, and there are several causes of instability. If you look at the 5 that I have listed here, that encapsulates almost everything: traumatic, pathologic, degenerative, iatrogenic, or congenital. And of course, traumatic instability is relatively straightforward. Someone's in a motor vehicle accident, they develop acute instability of the spine. Pathologic instability, I'm referring to either infection or tumor that erodes away part of the stabilizing structure of the spine and causes instability. In degeneration, this is something that we all get. I don't really like the term degenerative disc disease because it's something that happens to 100% of the human population. And so that in and of itself doesn't really fit the diagnosis of disease in my mind. But degeneration of, say, the facet joints, as Ivanka had mentioned, can lead to instability. And we see in the picture in the lower center an L4-5 degenerative spondylolisthesis causing that instability, with subsequent collapse of the disc space, because the disc space is not designed to resist translational motion, and eventually it gives out. You end up with the bone-on-bone arthritis. Instability can be iatrogenic, meaning that it's caused by surgery itself. So some of those great surgeries I just alluded to, in which we perform a lumbar laminectomy, may be the straw that breaks the camel's back and causes instability in the spine. That's actually very uncommon, but it can happen. And then congenital, meaning you're born without certain stabilizing anatomy elements of the spine and develop instability as a result of that. I include scoliosis in this, and scoliosis can be both idiopathic, which is the scoliosis that occurs in typically young women, but also some young men. And then it can be degenerative as well, which is the most common scoliosis that I see in my practice, in which variable elements of the spine degrade in asymmetric patterns, causing an image like we see on the right-hand side of this slide. And fusion, it's an alphabet soup. You've heard of many of these. It should be ACDF, anterior cervical discectomy and fusion, but then there's posterior fusion, anterior fusion, lateral fusion. Really what's most important is that last letter of the alphabet soup, the F, that is a fusion. And that means that we are taking away motion to stabilize an unstable spinal segment. And there's often cases that we need to perform a decompression infusion. In this MRI, we see that someone has developed a grade 2 degenerative spondylolisthesis of the L4-5 segment with likely impingement on the L5 nerve root and the accompanying physical exam findings. And in this case, if we don't also stabilize this segment, this is a patient that will develop worsening instability, and we will not be able to adequately decompress the neural elements that are affected. And so in this case, this is clearly an indication for both decompression and fusion. And this is the resultant surgical outcome in which we're able to reduce that grade 2 degenerative spondylolisthesis, restore normal alignment of the spine, and decompress the neural elements. And there are several different ways to do that. And I've listed these here, again, beyond the scope of our discussion. So quite simply, all we do from a surgical standpoint is stabilize unstable spines in the form of fusion. That's actually less common. Or we decompress neural elements in the form of decompression, which is my primary go-to procedure and has the highest success rates.
Yes, it's my turn. Okay, I'm going to speed this up a little bit because we've got not much time. We want to leave time for some questions. So I'm going to talk a little bit about the preoperative optimization for spine surgery. And again, this is not relating really to the acute radicular pain or to the myelopathic patient, right? We're talking about patients who have had longstanding symptoms, longstanding conservative therapy, have a surgically correctable pathology. How do we improve the outcomes for these patients going into surgery? So what do we know worsens surgical outcomes? Smoking. And I think at this stage in the game, everyone's pretty familiar with this. They're significantly more likely to experience pseudoarthrosis and postoperative infection, and also to report lower clinical outcomes after surgery for both cervical and lumbar spines. So helping those patients to stop smoking preoperatively will increase or will improve their outcomes and improve their health overall as well. The second thing is nutrition. And so we talk a little bit about this. So both overnutrition and undernutrition. And so overnutrition, meaning that body mass index has a significant impact on this. And what we find with people with high body mass index is that they're actually malnourished. And so there's a lot of things that go into this, but we know that low albumin levels and are independent risk factors for readmission within 30 days after an elective spine surgery and a spinal fusion. So there's a clear relationship between spinal surgical site infections and nutritional depletion. So maximizing that before a patient goes into spine surgery is important. Diabetes, again, we talk a lot about the comorbidity of diabetes, which really predicts worse patient-reported outcomes after spine surgery, and it also increases their risk for infection. And so maximizing their hemoglobin A1C is very important as we go into the consideration of spine surgery. Opioids, we talk about this a lot. Our policy here is to try to get patients under 50 morphine equivalents for elective spine surgery. There's newer protocols that are suggesting 30 morphine equivalents or less. And the reason for this is because we know that, again, outcomes are worse when we go over 50 morphine equivalents in patients going into surgery. And not just outcomes, but we talk a lot to our patients about how are you going to control pain after surgery if you're on 900 morphine equivalents. And we see patients that come in on 900, 1,000 morphine equivalents, have a surgically correctable pathology, but that outcome is going to be poor no matter what anyone does if we don't wean those opioids preoperatively. And then a little bit back to the nutrition is the obesity. And so we know that every 5 kilogram per meter square increase in BMI is associated with a significant increase in surgical time, blood loss, risk of deep infection, and DVT. And then, of course, reoperation rates. So we work very hard to get body mass indexes under 40. We'd like them to be under 35. And there's ways to do that. The American Board of Obesity Medicine is a relatively new board, and there's good algorithms for these patients that involve medication, that involve counseling, that involve a lot of different things. And we've had some great successes being able to decrease patients' body mass index before they go into surgery, allow them to have their procedure that's needed, and improve outcomes, both from the spine surgical side, but also from patient health overall. Other things that worsen surgical outcomes, sleep apnea. So there's a lot of postoperative complications such as unplanned ICU stays, reintubations, pulmonary emboli, serious cardiac events. So treating that OSA before we go into surgery will certainly help with outcomes there as well. So we talk a lot about sort of these alternative approaches. So you have a 57-year-old female with grade 2 dynamically unstable L4-5 listhesis and then the resulting radicular pain. No weakness, no other neurologic changes on the exam. BMI is 46, hemoglobin A1C 9.5. She smokes every day. She's done PT, chiropractic injection. She sees the local surgeon who works in collaboration with his team and the patient's primary care physician to meet these attainable goals prior to correcting that surgical problem. We feel like this is a reasonable approach to patients. I think a lot of times patients go into have a surgical consult or to have a consult for even sometimes for pain physicians, and they're essentially just told they're fat and get out when you've lost weight. And I think that we really do those patients a disservice because they know that and they've been trying in various ways most of the time. And so if we can offer some assistance there, help them to lose that weight and be able to get the surgery that's needed for them, I think we do a better job there. So having these attainable goals and a roadmap to get there will really improve their compliance and satisfaction. It improves their motivation to adhere to these recommendations, and their health is improved, of course, in innumerable ways. I should say a different word. And their spine pathology can, of course, be addressed as well. Next.
So I think many of those modalities that Dr. Jamieson mentioned are some of the most important in actually treating patients. And it's interesting to me that patients are very motivated by the idea of spine surgery. And often as we take care of the bone health, as we work on obesity, as we get people to reduce the narcotics that they're using and stop smoking, I've had several of these patients, upwards of 10+% that come in and say, you know what, my back feels pretty good. I'm not sure that I need spine surgery. And so, you know, it's very exciting for me in that regard. And that's why I like working with the group of folks that I work with as we attempt to optimize people. We're optimizing them for life as well as for a potential surgical intervention. You know, the things that in every branch of medicine, there's always cutting edge technologies, and spine surgery is no different. And it's sort of exciting to see what's on the horizon and some of the things that we're even doing right now to improve patient outcomes. And I often mention to my patients that if we look back 40 years, you know, 40 years from now and look at about 50% of what we're doing, we'll think it very barbaric. Unfortunately, we're not sure which 50%. And so it becomes difficult really to sit there and say what's going to change over time. But spine surgery is evolving very rapidly. I've been doing exclusively spine surgery for 15 years and do mostly complex deformity and revision spine care. And that space has changed dramatically in the last 15 years. So already, you know, in a relatively short amount of time, a third of the 40 years that I mentioned, you know, we see these differences and we see improvement in patient outcomes. And really where we see most of these differences in enabling technologies. And what these are ways in my mind to improve a surgeon's intraoperative senses. So in the past, what we've really been relying on is, actual visualization of all the anatomic components of the spine. And when we can clearly visualize those anatomic components, then we can perform a well-executed surgery that allows us to obtain the goals, say, stabilizing an unstable L4-5 segment. And what enabling technologies help us to do is to visualize those same elements without having to be as destructive to the surrounding soft tissue, and offers us more minimally invasive techniques. And so I'm just going to show some of these. What patients typically think of when they think of robotic assisted surgery is the picture on the left-hand side, in which you're dating yourself if you actually know this robot. Probably, who is it, Dr. Blitzer? Johnny Five.
Johnny Five's alive.
There we go. So not many even kids will recognize that today, but I actually was involved in a study in 2005 where we were kind of groundbreaking with robotic assisted spine surgery. And when we were enrolling people in this study, it was the easiest study I've ever done to enroll patients into, because they loved the idea of Johnny Five rolling in, guns blazing, doing their fusion, and then, kicking back some beers with the surgeons afterwards. Unfortunately, the picture that you see in the lower left is what that robot actually looked like. And so it's much less sexy. To be honest, at that time, I did about 25 total cases. It required quite a bit more time. It did save perhaps a little bit on blood loss and various other things. But for the most part, we were kind of excited when the robot broke down and would say, okay, let's move on to bigger and better things. At that time, though, I also felt that we were on the brink of something, that we're discussing, that we're finding things out. And sure enough, in the evolution over the past 15 years, we've continued to evolve in robotic assistance to the point that it is a little bit more ready for game time. Keep in mind, as I mentioned here, that robotic surgery is really only for fusion surgery, because it helps us place implants into the spine, and implants are typically only placed when we're trying to stabilize an unstable spine. And so in these cases, degeneration, deformity, and arthrodesis or fusion of the SI joint, this has found more wide acceptance and allows us to increase the senses that we have so that we don't need to disrupt as much soft tissue. And it helps primarily with both screw placement and inner body placement. And the inner body placement is what we place in the position of the disc to both restore alignment of the spine and to decompress spinal elements. And in this slide, I kind of show a CT scan that shows very narrow pedicles up at L1. And this surgery would have been very, very difficult using my standard senses, including intraoperative X-ray. And with robotic assistance, you can see that we were able to place screws sort of right down the strike zone, so to speak, along those very narrow L1 pedicles. And so as a result, surgery has much less radiation because we're not as reliant on intraoperative fluoroscopy, has less time, which means less blood loss and far less soft tissue disruption. And we've demonstrated fairly effectively that people recover much more quickly from minimally invasive techniques. And so different than Johnny Five, it's still not quite as exciting as the robot rolling in. But this is actually robotic assistance in spine surgery. And what we're using the robot in this case to do is to position ourselves so that we can get a good attack, so to speak, at that pedicle. And we can place this device with minimal soft tissue and muscular disruption. And so right here, I'm using a high-speed burr to prepare the space. I then use a drill, and the drill prepares the screw track. I'm looking at the screen so that I can see where this instrumentation is going based on intraoperative navigation. And then once I remove that drill, we'll put the screw itself into place. And then we stimulate that screw to make sure that it's not impinging on neural elements. The screen that I'm looking at, which shows the screw not impinging on neural elements, based on your technique, et cetera, can sometimes lie to you. So we always have fail safes and checks to make sure that this is machine is doing the job that we're asking it to do. And so this is us stimulating the screw, making sure it's not impinging on those neural elements. And this is again showing the robot move from one location to the next. And again, we repeat the process. Turn it back over to Dr. Blizzard here to talk about some of the other new and exciting things in spine surgery.
I'll keep the time going, I promise. So getting back to what Dr. Kent talked about, probably the most common thing we do are decompressions. So when it comes to disc herniations, that's laminotomies and discectomies. And these have a bunch of different names. These can be microdiscectomies, minimally invasive microdiscectomies, minimally invasive hemilaminotomies. There's a bunch of different terms for this, but it's all the same thing. People can use endoscopes, little cameras to do this. You can do it through a tube. You can do it behind your back. You can do it with a big incision, a small incision. And the bottom line is ultimately you're getting down to the same spot. And the evolution over the last 15, 20 years is that people are getting away doing smaller and smaller incisions. But ultimately, there seems to be some fine point of it needs to be enough visualization to see what you're doing, but not so big that it's unnecessarily disrupting natural tissues. So for most of us, it's doing an incision between kind of a little less than an inch to a little over an inch. Somewhere in there is pretty much the standard of care at this point in time. The benefit of this surgery is, again, it is the ultimate minimally invasive motion sparing surgery as it is. It's not a fusion, and it really requires only a very small incision to get down to a particular level to remove a disc. The complication with this, the biggest one is dural tears. That's that sac of fluid around your nerves. The tear rate of kind of puncturing that covering around your nerve is pretty low. And the overall disc herniation rate is about 15% at 8 years in this large study called the SPORT trial, which was many times brought up in the New England Journal. Other options here, lumbar disc arthroplasty. So this is kind of a new approach to treating a very specific type of back pain. So I know we talked about the majority of what we do are treat impinged nerves or unstable spines. There's a very, very specific narrow group of patients who are ideal for this technology. This is literally similar to the total hip and total knee literature, where we're replacing an arthritic, specifically an arthritic disc joint with a biologic artificial joint and maintaining the joints in the back, the facet joints. The people that are ideal for this are generally younger patients who have very specific loss of the disc joint, but normal behavior, appearance, non-painful facet joints. And these people, we take out the disc joint, we put in the artificial disc, and they maintain their motion. Even newer technology in that is a facet replacement. So this is the other way around. If you think about a partial knee replacement, this is kind of the both sides for partial knee replacement. So with a facet replacement, in this case, the disc, we need to be normal. These are people that have unstable or degenerated facet joints. And these people, the facets become painful or eroded or congenitally were malformed. And these people, by replacing the facet joints but preserving the disc joint in the front, they're able to have some decompression of their nerves while maintaining motion at the segment and avoiding a fusion. So currently studies are ongoing, and we are participating in studies for both of these to identify patients that are ideal for these technologies. These are not cut for everybody. I think they are very, it's very sexy to talk about the idea of motion sparing surgeries, but ultimately many people may get their hopes up thinking this is the ideal thing for them. They've been waiting 75 years for this disc replacement to come out, and now their spine is completely degenerated. They're ready to have a replacement. But unfortunately, it's not cut and clear who are going to be the best candidates for these treatments, and we're trying to tease that out right now.
Okay, so we'll move into kind of the changes on the interventional pain side. I would like to say that my 9-year-old thinks Dr. Kent is really cool because he gets to use a robot and play video games in the OR all day. And I try to explain to him that I'm also very cool. And the comment is, you're not as cool as Dr. Kent, which seems to be a theme for me. So I just go with it. Let's move on to spinal cord stimulation a little bit. So these are spinal cord stimulation been around since the late 1970s. But I think the advances and the changes in the technology in the last 5 to 7 years have made it so that it does not even compare to what we were using previously. Good indications for spinal cord stimulation: axial back and neck pain, what we're calling failed back and neck surgery syndrome, which we're actually going to probably start talking about that differently in the near future here. Complex regional pain syndrome, pain associated with peripheral vascular disease. There's some good data on that. Refractory angina, Neuropathic pain secondary to a peripheral nerve injury. These are good indications. Intermediate indications include things like post-amputation pain, intercostal neuralgia, spinal cord damage pain, abdominal pain, pelvic pain, although those two things are changing to become good indications, I would say, probably in the next 5 years here. Poor indications are everything else. Perineal or anorectal pain, things that are unresponsive to SCS are complete cord resection, non-ischemic nociceptive pain, and things like nerve root avulsions. Previous challenges with this technology, there was problems with lead breakage, battery problems, and then the biggest problem, in my opinion, was long-term results. And I think that still remains a challenge, but I think that is changing significantly. So what's new in this field? The first thing that's new is that there's evidence. We have level 1 data for a lot of these different things, large randomized controlled trials, proving efficacy and proving longevity of the therapy and the ability to do things like reduce opioid consumption in these patients. The frequencies we're using are very different. The MRI compatibility is different. The indication is different. And then, of course, the ongoing randomized controlled trials, I think, are very important. So when we talk about the randomized controlled trials, the first randomized controlled trial of its kind was the Senza trial, where 171 patients were randomized and followed out to 24 months. And this chart shows significant reduction in their VAS scores all the way out to 24 months here.
So when you say long-term pain management, what are you shooting for? 10 years? What is the goal with that?
That's an excellent question. So when I talk to patients about spinal cord stimulation, I say, this is not something that we want you to have in for 2 years, 3 years, and then want it to come out. Now, can we use it that way? Probably. And some of these slides, I think, will show a little bit about cost effectiveness. We think that the cost effectiveness probably happens around 18 to 24 months as far as opioids and system utilization, that sort of thing. And so most of our data now is only out to 24 months. I think that is probably a shortfall, and I know that we're continuing to monitor that and hopefully get that out to 5 years. But I think that's kind of probably one of the challenges that we'll continue to face is what does long-term look like? How long are we defining this? I have plenty of patients who have come to me from other places and have had, a system in place for 15 years, and we're changing the battery and doing these sort of things. But we have other patients that we see who, for some reason, sort of stop responding at this 24-month mark, and then what do we do there? I think we're mitigating that risk to some degree by being able to alternate these frequencies. We can do multiple frequencies at the same time. As the battery technology changes, the long-term outcomes seem to become better. So this, let's see. So this chart shows the profound long-term back and leg pain relief with high-frequency therapy out to 24 months as well. And then this kind of compares what we've seen previously. So initially we were talking about 32% pain relief, and we were saying, yep, that's great, that's a responder. And now I think that discussion has changed. So if I have a patient that comes back from a spinal cord stimulator trial and says, I got 30% pain relief, I say, not good enough. That's not good enough. We need more than that in order to make impact and quality of life. And so now we're starting to see responder rates upwards of 84, 83%. There's some discussion about those are sort of super responders, but that's significantly better than a 30% response rate, which we had for the first 10 years of this therapy. The same randomized controlled trial showed decrease in opioid consumption as far as morphine equivalents, and then the percentage of patients using opioids. This is an expectation in our practice that we will not implant a patient who is on high dose opioids, because we know that the outcomes, just like with spine surgery, are worse when we implant patients who are on high dose opioids. So we can do that one of two ways. You can wean the patient down before offering them a trial. The beauty of spinal cord stimulation, you get a 7-day trial of the device. If it works, great, we'll put it in permanently. If it doesn't, no harm, no foul. We pull those leads out and you move on to the next thing. But sometimes we use the trial as sort of a way to get some buy-in for patients who are having a hard time weaning off their opioids. If I can get you significant pain relief, then you're much more motivated to wean down on those opioids before you have a permanent implantation. Dorsal root ganglion stimulation has been around now for probably the last 3 to 4 years, predominantly used for things like complex regional pain syndrome, ilioinguinal, and other targeted pain complaints. It's really great for post-surgical total joint pain. So by definition, this is a complex regional pain syndrome type 2, causalgia. Someone has cut into that area and it has CRPSE type symptoms. We used to talk a lot when we talked about complex regional pain syndrome about the Budapest criteria. And what we've learned over the last 10 years is that that's not required to still have a diagnosis of causalgia or complex regional pain syndrome. And that's sort of the definition of type 2. The data here is out to 12 months, and it's a randomized comparative trial. And these patients seem to do quite well with dorsal root ganglion stimulation, as you can see. We've now moved into another century of wireless stimulation coupling. So some patients don't want a battery implanted. We're able to have an external battery that powers the two wires that go into the spine. MRI compatibility has changed dramatically. The majority of systems are now MRI compatible to some degree. And when we say MRI compatible, I should say that that's MRI conditional. So there are conditions that have to be met for the MRI to happen. Complications with spinal cord stimulation, fortunately, are rare. Paralysis, there's been one reported case. Infection usually resolves when you take the device out. Lead migration is probably the most common complication. So there are ways to mitigate that, but it is still definitely a complication that can become frustrating to the patient and to the implanter as well. Oftentimes we can program around that if the wires move up or down a little bit, and sometimes we have to go back in and reposition those. Epidural bleeding, very rare, but when it happens, it's devastating. Seroma and CSF leak, which can lead to post-dural puncture headaches. Cost effectiveness, this is a very old study. So our data on this is from the late 90s. I think I was still in high school. Blizzard, you were probably 3 or 4 years old. So the cost effectiveness of back surgery or of spinal cord stimulation has been shown. And it seems to be more cost effective when other things fail. And that's kind of why it got this position as being sort of a last ditch effort for patients, right? When you've tried everything else under the sun, including opioids, then you're considered for spinal cord stimulation. I think that paradigm is changing and will continue to change as we start to see more evidence, more long-term data on this as well. In those patients, this goes back to that 2.1 years. And again, I think the argument is that this is 1997 data. And so in 1997, the technology was vastly different. And so hopefully now we should start to see new data coming out showing that that cost-effective point is significantly less than 2.1 years. And this chart shows the same thing there. We'll move real quick into peripheral nerve stimulation and then.
So peripheral nerve stimulation is going to be similar to spinal cord stimulation. The only difference is we're targeting peripheral nerves. And this is just kind of some more of the physiology regarding how it works. But it works both peripherally and causes changes in the spinal cord as far as, affecting the neurotransmitters in the spinal cord and how it processes pain. Peripheral nerve stimulation from an outcome standpoint, has been just kind of a newer resurgence in the therapy. But this particular study looking at 72 patients who underwent a peripheral nerve stimulator replacement, most common indication was occipital neuralgia, followed by lower extremity neuropathies, like mononeuropathies after some sort of injury. This was associated with 6-month reduction in pain scores from about a 7 down to a 4. They also showed an opioid utilization from about 60 morphine equivalents down to 18. And so it's been found to be very effective for patients with specific pathologies. As far as side effects or not side effects, adverse events, they did have about 10% had some sort of post-surgical site infection in which they had to be removed. And so that is something that for all these devices, there are those risks. There are a lot of companies out there and there more and more are coming out with newer, smaller devices. These could be both, most of these are powered externally, but this space is rapidly evolving. Potential candidates, any sort of patient with post-surgical joint pain in the shoulder, knee, ankle, or kind of, there are options. Also painful neuropathies, such as the ones listed, are all potential candidates for peripheral nerve stimulation. It involves testing. If we numb up that nerve, typically it's done with ultrasound, does it block the pain? If that's the case, then we can proceed to the next step, which is trialing the device for 5 to 7 days. And if that sufficiently improves their pain, then we move on to permanently placing that.
So we'll move it a little bit more into these sort of newer technologies on the pain side that treat things like spinal stenosis. So the predominance of this is for, as Dr. Kent, I think aptly said, that lumbar laminectomies have been around for hundreds of years and are excellent surgery with wonderful outcomes, right? So we're not, in the pain space, we're not trying to replace what we know works. What we're trying to have is alternatives to patients who are not candidates for that, right? If the patient comes in on end-stage renal disease, has to dialyze 5 times a day, is on 7 liters of home O2, and has a hemoglobin A1C of 10 with significant neurogenic claudication, you're going to be hard pressed to say that's a wonderful surgical candidate. So being able to offer alternatives, I think really helps a lot more patients be able to get some relief. So indirect spinal decompression for lumbar spinal stenosis is again for neurogenic claudication. So that pain that gets worse when you walk, better when you flex or sit down. The particular device, it looks like this. It kind of has a claw, it goes in between the spinous processes, and it's an extension blocker, right? So when we talk about patients who walk through this grocery store leaning on the cart, it's because when they stand up and extend, that pinches off the canal. So if we can prevent that from happening using a small device and a 1-inch incision, then we can improve symptoms. The Vertiflex procedure has long-term data out through 60 months that shows 90% patient satisfaction rate. And I kind of cling to that because ain't nothing I do that gives 90% satisfaction rate at 5 years, I can tell you that much. So that's pretty exciting when we saw all that data come out. So this is an excellent option for these patients. It's outpatient. Dr. Kent and I have both done these with local only for patients who really can't even tolerate any sedation, maybe 1 to 2 sutures and no distortion of the anatomy. I think that's important because if in the future these patients were to require a significant surgery, then the anatomical distortion is something that our surgical colleagues worry about quite a bit, because if they can't see where they're going when they're trying to go in there, then of course that can create problems and lead to complications as well. And this is what the little devices look like when they're implanted here. It's indicated for the lumbar spine only, 1 or 2 adjacent segments. This next option has been actually around since I was a fellow, but kind of went away for a while and is kind of coming back a little bit. So this is what we call the MILD procedure, which is a percutaneous guided lumbar decompression, where really what we're doing is looking for patients with a hypertrophied ligamentum flavum. So there's lots of causes for spinal stenosis, as we've discussed. One of those is a thickened ligament. And so we're only addressing one of those problems, but the data on this, again, is still out to 2 years, and the safety profile I think is something that's pretty important. It's as safe as an epidural. So this is really for, in our practice, is for patients who are just really not good candidates for surgical interventions. And I think that it allows us to have something to offer those patients that can improve their quality of life short of a spine surgery. Again, it's outpatient, minimally invasive, it's safe, and it's certainly an alternative for those who are not candidates. The most recent thing that's come out is multifidus stimulation. This is pretty exciting. There's the multifidus, of course, being the small muscle spine stabilizer. And so there's a lot of patients. This patient population is kind of your 40 to 55-year-old patients with chronic low back pain that are otherwise pretty active and try to be active and healthy. And so this essentially is internal physical therapy is the way I like to think of it. So we put 2 little wires into the spine at the L3 level, and for 30 minutes twice a day, they have internal physical therapy. There is an implanted battery that does that. The interesting thing with this is that we have to discuss with patients that you're not going to get better right away. It's like any physical therapy. It's going to take some time. So the data for this, again, is out to 2 years now, and the patients continue to improve from a disability standpoint and from a pain standpoint. And then finally, we'll move on to this one more thing, and then we'll...
So this last thing we're going to talk about is ViaDisc, which is ViaDisc is basically a disc, intradiscal injection for people with very specific causes for low back pain attributed to the disc itself, which, like I said, is going to be a very, very small subset of patients. This is a prospective randomized parallel arm multi-center trial. I'm looking at patients at 6 and 12 months after this disc injection, which is basically an allograft injected into the disc compared to the placebo and conservative care. The graft itself is basically taken from cadaveric samples and ionized or chewed up and basically resuspended and injected back into the disc. They initially were trying to get up to 200 patients. They ended up only enrolling 24. 16 received the active allograft, placebo 4, and conservative care 4. So this was kind of all their screening criteria. Looking at Furman grade 3 to 6 degenerative disc disease without other causes for low back pain, basically. And in this very small study, they were able to demonstrate a significantly reduced pain, back pain, for the patients who received the active allograft compared to the conservative care. They did have all their patients cross over because they wanted this disc or this injection, and they also saw great results out to 12 months. This was similarly found with the disability Oswald Street Disability Index. And so this is a newer FDA-approved injection. I think that this is something that we're excited to offer to patients for this very specific indication. But I think there's also needs to be a lot more studies looking at this going forward. And so this is something that's out there that we're kind of keeping in the back of our minds.
So we'll address this quickly. And again, we want to be able to get on to your questions. And if you're like me, even though I do this for a living, I feel a little bit like I've been drinking from a fire hydrant tonight. We could literally have a week-long convention about these topics that have been presented. And we're hoping to just give you a thumbnail sketch on many of these things. And you know, research does matter in medicine, and we feel very strongly about this as an organization, and we feel that it is within our mandate to continue to sort of push this technology in a responsible way. And there are lots of things that we haven't even been able to talk about tonight. The things that we've brought forward are some of the things that are new and exciting. There are several other things in the realm of spine care that you may be familiar with, including alternative medicines, other approaches that are exciting on the physical therapy front that could be discussed in detail, all sorts of other things that this field is very exciting. But one of the things that I just want to kind of drive home is that you know, there's a problem in recognizing any one of us as providers. In this slide, I put the spine surgeon, but any one of us providers is the end all be all for spine care. And the problem in referring, say, to a surgeon, and this is a problem that I encountered relatively fresh out of fellowship in active duty military position, in which I saw a lot of folks with back pain. And I had frequently the conversation with patients that I wasn't really a back pain specialist. That again, Dr. Blizzard and I have sort of spoken already, that we're more specialists in either stenosis or instability. And while those things can contribute to back pain in and of itself, primarily in a young 30, 40-year-old active person, often is not related to either of those things. So the danger in referring to a surgeon is that one, you might be getting surgery, and that can be in some cases dangerous. And so, you know, if our patient is a screw, the last thing you want to do is send them to a hammer. And what happens more often than not, and we address this a little bit, is that the patient is told by, say, the spine surgeon in this case, or maybe any one individual subspecialist in this field, that I'm sorry, I don't have a solution for you. And what the patient really hears is that they don't have a problem. And then all of a sudden, you as a referring provider who trusted the care of this patient into a subspecialist, all of a sudden has this patient knocking down your door again saying, man, that was the worst experience of my life. It was a waste of time. He told me that I didn't even have a problem, and they've got no solution for me. And really, we need to move beyond that. In this world in which we have increasing subspecialization, it becomes more and more important to understand that we need to work together so that we can provide the best care for these patients. There's a pattern in this. In hospital systems, frequently tumor boards are hosted in which surgeons, radiologists, oncologists, et cetera, come together to discuss patients. And these are challenging patients with many elements to their pathologic condition, and spine patients are no less challenging. And unfortunately, we're probably undertaught in this regard as far as back pain and how to respond to the spine patient. And as a result, it becomes very difficult as a primary care provider or even as a well-trained spine surgeon to be able to adapt to all these different modalities and things that are available to treat these patients. And I became very frustrated with this early on in my career, and I realized that if I surrounded myself from the right individuals, I could change that patient experience from, I'm sorry, I've got nothing for you, you're not a surgical candidate, to, I'm sorry, or to the conversation where I would say, thank goodness you don't have a spine surgical problem, but I'm going to get you to the appropriate specialist. And so who belongs in this type of multidisciplinary care? A lot of us are sitting here at this table, spine surgeons, interventional pain specialists, sometimes interventional radiologists, physical therapists, physical medicine specialists. Often there's a psychologic and sometimes even a psychiatric component to these spine patients. And all of you who treat spine patients realize this. And so when I began assembling a team of interdisciplinary spine care, we had pain psychology. We had people that would counsel folks for weight loss. We have chiropractic care and capabilities. And really what you see, the last bullet is often these patients just need a cheerleader and they need reassurance that things will be okay and that we have evidence-based technologies and modalities that can help deal with their problems so that we can provide them the best potential outcome. And it's not any one of these pieces of the puzzle that solves the problem, but it's rather the interplay of these things. And it's important to recognize that if we rely on one of these modalities too heavily, say surgery, then obviously people can be damaged and wounded by surgery. We're in the midst of an opioid addiction epidemic, and it was because opioids were thought to be the key ingredient to solving this problem. As it turns out, this treatment strategy can also be very damaging. So as we come together and develop sort of this multi or an interdisciplinary approach, and these terms are used somewhat interchangeably, we hope that we can provide a little bit better care. And if you're interested in these slides, I would recommend that you contact us and we'll be happy to send these slides to you. I'm just going to sort of speak in the background while I go sort of through some of these studies so that if you review this later, you can look at the studies themselves. But this is a study that came out of Canada in which they were trying to reduce costs associated with complex imaging. And they found out that if MRI utilization and referral was controlled by a multi-specialty group of spine care individuals, that they could save money in unnecessary complex imaging. Here's another one in which we were able to demonstrate that folks were less likely to need surgical intervention if the pathway to a surgeon was controlled by folks that had knowledge in spine care, either a physical medicine specialist or a physical therapist often, or interventional pain specialists, et cetera. And then this was a study that I actually helped with in the Navy, in which we compared ourselves to another large naval facility that did not have a multidisciplinary spine team, and we were able to actually develop functional outcome scenarios in which we could return people to full active duty much more quickly by taking this sort of tumor board approach to these complex patients. And it was these are patients that several federal dollars are wrapped up in, and it's in the best interest of the government and everyone to get these folks back into their jobs as soon as possible, and we were able to demonstrate this. And so the evidence continues to mount that, again, it's not a single approach. And I mentioned already that, you know, my greatest goal when I engage a patient is to sort of look at what's been done already, determine whether they're a surgical patient, but along as well as determining that they're a surgical patient is maximizing the potential benefit before surgery. And my greatest joy comes in the patient who comes in before surgery and says, I got to tell you, I haven't really had the pain that I brought to this clinic in the last 6+ months, and I'm not sure that I want to have surgery. And those are the first patients that I say then don't have surgery. Just remember these things and you know, continue to work on weight loss and controlling your diabetes and nicotine cessation and all these things, as well as developing biofeedback mechanisms and other tools in the tool shed to sort of help with these ways to avoid back surgery and to improve patients' state of life. I love the idea of pain psychology, and it was interesting to me that frequently when I've referred folks to individuals in this subspecialty, I get pushback from patients, yet I wouldn't have a single patient come back and say that that was wasted time with the extra tools that they learned. And even if it aids them in their post-operative recovery, it's still time well spent. And so there's, you know, we looked at a lot of data with a lot of positive outcomes, but psychological counseling can be just as positive as a lot of our most well-studied surgical interventions. And so it's important to remember these things as another aspect of treatment. Engaging our physical therapists and our occupational therapists and really focusing on functional rehabilitation and meeting functional goals. It's not often realistic for an 85-year-old to return to their 18-year-old self, and really developing those functional strategies and helping them understand that can go a long way to avoiding unnecessary surgical interventions when they're looking for the fountain of youth. And then there's all sorts of different treatment strategies and adjunctive therapies, et cetera, that fit into this. One of my favorite actually listed on this slide is simple things like yoga and Tai Chi, which are largely isometric core exercises with hyperextension based therapies. And we already heard Ivanka talk about, you know, the importance of those therapies. And it also provides community for patients to function in. And so, you know, the real purpose of us being here and having this conversation and hopefully trying to keep it easy as possible is understanding that the longer that a patient has to deal with pain, the worse outcome that they're likely going to have. And so my recommendation to anyone who's considered spinal referral is, by all means, take care of that patient as long as you feel comfortable taking care of that patient. But at that time frame where you feel that this is beyond the scope of your practice, or this is something that you don't feel comfortable managing anymore, then an early referral can be very helpful. And hopefully avoiding too much narcotic use, sometimes avoiding unnecessary expensive imaging modalities, et cetera. And when we all work together for the good of the patient, we can be very effective in developing these treatment strategies that really do give outcomes. So again, probably the biggest impediment to everyone developing this style of care is really the idea that third-party insurance payers haven't bought off on this idea yet. But I think as we begin really exhibiting good patient outcomes and publishing this data, and you see more and more of this data coming to the forefront, then our insurance companies, commercial insurance companies, are going to take note and be much more excited about this approach to care. And many of these studies are designed to demonstrate cost efficiency, et cetera. And so really, as we start reporting our outcomes and find good reimbursement strategies in the prevention of worsening spine degeneration and pathology, it's an exciting place to be right now, just as exciting as robotic assisted surgery or neuromodulation, et cetera. And so we'd like to open it up for questions. One of the questions that we've seen come through already is that patients will frequently come into the clinic wearing a brace of some kind, usually lumbar or cervical. What are your thoughts on the benefit of stabilization with a brace, depending on the underlying problem, and for how long? And this is an amazing question. It's interesting because I'll have a number of patients actually come to me and ask about the utility of bracing. I would tell you that your first question should be, who put you in the brace and why? Because if they were in a rollover MBA 7 days previous and they were diagnosed with a C6-7 fracture of some sort, then even me, I'm going to be the last to try to rush them out of that brace. So I guess the lesson learned in that case is that braces can be very effective in treating acute pathology associated with the spine. And so the very first question I'll ask, and someone say with lumbar radiculopathy that went to Walgreens and said, hey, I bought this brace. When I put it on, what are your thoughts? They'll ask me as a provider. And the first question I ask is, well, is it making a difference? If it's making a difference, then I think that brace is worthwhile and can be used during the acute phase of that problem. I immediately also explain to those patients, though, that brace is providing sort of external stabilization of the spine. And they may be using it to treat some type of lumbar instability. But as we've learned in all of musculoskeletal medicine, that instability, I should back up a second. Stability in any joint, whether it be the spine joint, the shoulder joint, the knee joint, is provided by two different mechanisms. One, static stabilizers, such as, say, in the knee, the anterior cruciate ligament or ACL, and the medial collateral ligaments are in the spine, this ligamentum flavum that's been referred to several times, or the facet joints, the disc joint, et cetera. Those are all static stabilizers of the spine. But when they fail, there's a secondary system, and that secondary system is the dynamic stabilization of the spine. And Ivanka probably understands this better than just about anyone, but that's really recruiting the muscles, say the rotator cuff for the shoulder or the quadriceps muscles, specifically the vastus medialis, to help stabilize the knee. In the spine, it's these paraspinal muscles. It's our core strength muscles. And believe it or not, I've known folks with a grade 2 or grade 3 degenerative spondylolisthesis that with the correct recruitment of dynamic stabilizers, meaning good core strengthening, that they can avoid surgery perhaps for a lifetime. And so what that brace does is robs that patient in the long term of developing that dynamic stabilization of the spine. So I have this discussion with patients and I try to help them understand that a long-term use of the brace may be counterproductive for what they of the spine to heal, but there should also be an immediate plan to be able to wean that patient out of that brace and to return them to recruiting the dynamic stabilization that's going to give them better long-term support. So that's a long-winded answer. Any other contributions at all?
If somebody says they have a lumbar brace that helps them, that person is demanding physical therapy. That person wants a six-pack and core stabilization. So if somebody has long-term back pain, they say, gosh, I put a back brace on, I feel so much better. I say, you need physical therapy, period. That's no question. So I always tell everybody, do you have a six-pack now? And they always say no. least my patients say no. I say, well, you have one, that's what a lumbar course would feel like. You know, that cinch down, firm core stabilization is what somebody with minimal abdominal fat and strong musculature is gonna feel like. Post-operatively, when we use them for different reasons. Sometimes, like Dr. Kent said, we use more robust, big braces that can look kind of crazy looking to hold people in place if they have an unstable fracture. And after surgery, we often put little braces as a check ring. I tell everybody it's almost like a dog collar. My goal is that when you push on that brace, I want to remind you not to bend beyond that. Now, anyone can push through a brace unless it's a rigid, hard plastic brace. They can still kind of push through it, but I want people to stop when they feel resistance and say, yeah, that's that amount of restriction and motion that we talked about.
Yeah, and usually I'm saying to people that come in with them, you shouldn't be wearing that for more than 6 to 8 weeks, you know, for acute management of something. And generally, any studies have shown, you know, it takes 6 to 8 weeks to really start getting some strength gains with something too, starting a program. And, you know, and that's probably, I talk to people about that every day. People come in and by their 3rd visit, they're like, well, I don't feel any better yet. And I'm like, well, shoot, you know, you didn't get this problem just overnight either. So it's like, you're going to need to put in some weeks. And usually by that 6-week mark, they're saying, oh, I can see there's light at the end of the tunnel. I can walk farther, not as frequent pain, not as intense, you know, but it's going to take some actual work to get to that. And I'll just say to them too, it's like training for a marathon. You don't just come out of these surgeries and then go back to where you were. Like, boom, you start right off, you know, oh, I used to walk 5 miles a day. So here I go, 5 miles. I'm like, wait a minute, you haven't done anything for 3 months now. So a lot of that is like, we've got to get you just conditioned like anything, training for a race, training for your life, get you back to that functional capacity level to do things without passive stabilization.
I describe physical therapy like a diet. People say I went to physical therapy 3 times and I didn't get any better. It's like, that's like saying you had 3 salads and you had 2 this week and 1 the week before, and you understand why you're not losing weight. I tell everybody the goal of physical therapy is to understand changes you can make, do them every single day, and give it weeks to see the response to it. You know, just like eating salads. If you ate salad, you know, people think they can't lose weight, but if you eat salad 3 times a day, every single day for multiple weeks, you're going to see a change. But if you have one, you know, twice a week, you have someone observe you eat lunch, you know, eat salad for lunch, and you go back to your normal habits, you don't work on that interim, you're not going to see improvement with it. So a lot of what I do, honestly, when I meet patients that I think physical therapy will benefit, is I need to sell them and get them engaged in the idea that it's going to work, but they need to commit to the idea they're going to do some of this work on their own.
Yeah, and that's really what we look on. And I think that even is on my little stack card now too, is just that it's going to take some commitment and effort to really get the results out of any of these. And, you know, I look at part of what's exciting to me about this team is just to say, how can we really optimize all these outcomes for people too? Pain management, get the surgery, and then get you back to life. And it's going to take a little bit of work and diligence to just get that functioning level back and your strength back. And most people, you know, that's what I'll say. It is like doing any activity. You've got to put in a bit of training to get to that max function, to do whatever it is that's important to you. Lifting your grandkids, working in the garden, walking every day. It's just going to take a little bit of training to do that. So.
Okay, if there's no more questions, we'll probably wrap up here. So you've got 48 hours to claim your live CME credit. You'll get a link that will be emailed to you for this as well. And we'd like to just thank you for joining us tonight. And as always, feel free to contact us if you have any other questions.
And again, all this material is going to be available.
Yes, well, you'll get a link tomorrow with the YouTube link for this entire presentation as well that you can send to your friends.